Good morning. Good to see you on this Wednesday morning. And of course, I hope that you're well, wherever you're watching us from. This is Your World. And my name is Winnie Lubembe. So much to cover within this hour. So I hope that you will stick around until the end of the conversation, because today we want to understand the TB burden right here in the country. Because as we all know, World TB Day is usually marked on the 24th day of March every single year. But of course, again, like we always say, we're always ahead of things. Okay, so we want to start the conversation today. And of course, just get to understand where are we, as far as the TB burden in the country is concerned. Are we seeing an increase in the numbers? Are we seeing a decrease in the numbers? What are some of the latest interventions? It's a lot, all right, to cover during this 1 hour. So like I said, you want to stick around until the end of the show. But if you're watching us and of course you want to contribute to the conversation in one way or the other, either you want to share your story or you have a question, the panel is here to answer all your questions. So at NTV Kenya, both on Facebook and on Twitter, is how you can reach us, and tag me as well at Lubembe_Winnie. So let me introduce my guests for today. And of course, I'm going to begin on my immediate left. This is left, right? And of course, we have Dr. Margaret, who's the acting CEO, PS Kenya. Good to see you this morning. How are you doing?
I'm doing great. Pleasure to be here.
Karibu sana. And of course, next to her, we have Jerusha Anyango Oduor, who is a TB champion. And of course, she is here to share her experience and her story, so that again, to help us really better understand, TB, all right? And of course, Jerusha, asante sana, for making your time to be with us this morning. And of course, last but not least, we have Elizabeth Mueni, who is a County TB Coordinator, Nairobi County Government. So good to see you. Karibu sana.
Thank you.
On the show. And of course, we're just going to start with the day, right? And that is the World TB Day, which again, like I said, usually marked on the 24th day of March 2023. So Dr. Margaret, let's just start with you, right? TB, and what exactly does this day mean to us? I know we are like 2 days ahead, of the day, but what exactly does it mean, and where are we as a country?
Fantastic. TB is one of the leading causes of death. Yeah. And in Kenya, it's actually ranked the 4th. It is a big burden. If you look at the year 2022, in this country, we diagnosed up to 90,000 cases of TB, which is a big issue. But unfortunately, people are not talking about it as much as we want people to talk about it, because indeed, there's a lot that can be done to reduce this TB burden. Then out of these 90,000 cases that were diagnosed in the year 2022, the government estimates that up to 40% of cases were missed. So there's still so much more. There are many people out there who have TB. They don't know they have it, yet there has been so much advancements. There's treatment for TB. It's very easy to diagnose it, and there's a lot that really needs to be done. So as we prepare for World TB Day, we want the conversation. We want people to talk about it, to be aware that it can be diagnosed, it can be treated. And the theme for this year for TB is that yes, we can end TB.
Absolutely.
It is not a one person's affair, but it's about multiple stakeholders really coming together towards working towards ending TB.
Absolutely. And of course, we'll figure out why exactly do we experience cases of stigma for TB, because like malaria, we hardly see people being stigmatized for malaria or any other, disease or condition. So why exactly do we have a lot of cases of stigma, especially when it comes to, TB? Of course, Jerusha, you'd also tell us whether you experienced any form of stigma, or not, as far as TB is concerned. But of course, Elizabeth, for you, just take us through, because majority of the times we hear the word TB a lot. Even a small child can sing the word TB, right? But then again, sometimes understanding what exactly the disease is all about, what are the symptoms to be, on the lookout for. Can you just help us really understand that, so that we have a better understanding, when it comes to TB?
Thank you so much. And as you said, TB has been there for a very long time. It's an airborne disease. And we have the cardinal signs for TB, which is cough. And we usually say cough of any duration, because you'll find the people that are coming to the hospital, you cannot come to hospital because of a day cough. So it's cough of any duration, and children that are coming, the presentation for children is a bit different. So we have cardinal sign, that is a cough, and night sweat, and this night sweat is a severe night sweat, not the normal night sweat, until drenching night sweat. Then we have weight loss, because it's a chronic disease. You'll find somebody has lost a lot of weight, and it's a bacterial disease. So this person comes with a fever, and the fever that we have in TB, it's not the high peak fevers. It's intermittent fever that comes and goes, and this is a patient you find they have cough for maybe a week, they are sick. There are people who have used other drug, and as Dr. Margaret said, we are really missing TB cases because of the presentation of the TB. You find people consider cough as a normal. Yes, cough is not normal. Today you cough, you'll not go to the hospital immediately. You'll try your own remedies before going to the hospital. And those we are seeing at the hospital, they'll tell you this is a cough of one day, which is not a cough of one day. There are people who have been sick. So it's very important to take very important, once you're coughing, just not could be TB. Children presentation is a bit different, especially the young ones. You'll find that they're not gaining weight properly, so they have delayed mass tone. These are children that are not playfulness. They are dull in their own way. So that one is what I can say. But one thing to note, cough is one of the major signs that we are really looking. And we have night sweat, we have the fevers, chest pain, and also now the weight loss.
And you know, again, like you rightly put, most of the symptoms, I mean, they mimic so many other you know, issues, and majority of us would easily look for, you know, what dawa. Right? It's one of the things that we usually run to, you know, in terms of self-medicating. But when you talk about the cough specifically, because you said this is one of the key symptoms that, you know, you look out for, we usually hear people say, I have a dry cough, you know, when I cough, my chest is in pain and all those things. So is there like a specific type of cough that you look at, or cough is a cough?
A cough is a cough. A cough is a cough. Is now when we come to the diagnosis, because we usually use the sputum to diagnose TB. But you'll have, as I'm going to talk about it, there are different type of TB. You can get TB outside the lungs, which the cough will be dry. Even some will come without a cough. And they have TB because of the presentation outside the lung. So the cough that is in the lung, the TB that is in the lung, what we call pulmonary TB, they present with that cough. But once it has gone outside the pulmonary, then some will not even have the cough.
I see that. All right, and of course we'll come back to really understand the different types that you said. So Jerusha, let's go back to May 2021, right? So you were diagnosed with drug-resistant tuberculosis. Could you just take us back then? What happened? What are some of the symptoms that you presented with to the hospital?
Yes, it was on 2021 May. I became sick. Everybody, when I go to job, people tells me, Jerusa, you are not well, go to hospital. But I feared going to public hospital because I thought if I go there, they'll deny me, but I'll lose my job. So I used to go to chemist, buy drugs. I used to take these drugs for several times. Then it came a time that drugs is not now working on my body. So it forces me to go to a public facility. Being that I stay at Dandora, Dandora Phase 4, I went to a public hospital there called Dandora 2 Health Center. And when I go there, they took me to the laboratory and directly took me to a TB facility. And when the doctors of TB there looked at me, they tested my kikohozi, then they found it is a TB. Not just a TB, but a DRTB, a multiple drug resistant TB. So they looked at me, I was very weak. TB has affected me for several times. So it was my first TB, I never had TB before. Then they directed me to go to Kenyatta National Hospital. They told me, don't go back to house. Take this letter, go to KNH. I had my SMH by that time. They took me to the hospital. When I went to Kenyatta, they admitted me. First, I was taken to Ward 8 when they were still testing which is the kind of disease is affecting me.
Yeah.
Then they found it is a DRTV. I was now taken to isolation ward.
I see that. I see that. Okay. All right. So, but in May is when you got your actual diagnosis. But before then, you said you were sick and you would go to a chemist, you know, buy drugs here and there and all those things. So, what exactly were you? Like, did you notice? Did you notice, you know, what Elizabeth said?
Yes.
Fever, usiku kilala, a lot of sweating and all those things?
Yes,
Yeah.
I was feeling fatigue.
Okay.
My joints were weak.
Yeah.
I was coughing every day. Even if I'm at job, people are now scaring. I was coughing every time.
Yeah.
I was feeling hot, more so at night.
Yeah.
I told my children, please open the door, open the window so that I can feel a bit fresh.
Okay.
But it fails until I went to the hospital. It's where I got the solution.
I
Yes.
see that. And Dr. Margaret, do you just want to comment on what she said? That this is the first time she was actually diagnosed with TB, but now her diagnosis was you said multiple drug resistant
Yes.
TB. Is this more of a burden that we're dealing with in the country, that is the drug resistant or multiple drug resistant, or what exactly happens? And then I think Elizabeth will comment on, you know, the whole question of first time diagnosis and you already, you know, diagnosed with drug resistant TB. But let's start with you, Dr. Margaret.
Yeah, sure, yeah. A drug-resistant TB is one of the hardest forms of TB to treat.
Okay.
Fortunately, there is treatment that is readily available in the country. So some of the challenges that we see, which Jerusha has already pointed towards, is late diagnosis.
Yeah.
So most people present in the first, either a pharmacy or the small clinics, and there they are misdiagnosed often because they end up being treated maybe just for a normal cough or very non-specific symptoms. And then looking at TB as a disease by itself, sometimes, and Mweni has already touched on this, about extrapulmonary TB. So TB does not affect the lungs only.
Okay.
It can affect every part of your body, except your hair and your nails. But every other part of your body can get TB.
Okay.
And sometimes the symptoms are very non-specific, and you find people go to hospital over and over and over again, but there's no diagnosis that is really being found. So that's where partners like PS Kenya and many other NGOs come in and working very closely with the government to support in that. So as PS Kenya, we work in the we target the private sector in addition to the public sector. So why the private sector? Because 50% of Kenyans access healthcare services through the private sector.
That's true.
And by the private sector, I don't mean the big hospitals. I mean the pharmacies, the
private clinics.
The private clinics. That's the first place where if any of
People
us
would
fall
go.
sick, that's the local doctor.
And we see a crop of them in our estates, you know, here and there. So
Exactly. And sometimes they may be left out from the larger healthcare system. So that's where we come in to support in training them so that whenever anyone walks to that clinic or pharmacy, they are able to have a high index of suspicion and suspect this might not be the normal cough. It could be TB, and they link with other systems of the government to be able to diagnose and also to get treatment.
Absolutely.
As well.
Again, like you said, the symptoms mimic other things. So high index of suspicion will be really, really, key, and especially when it comes to diagnosis. All right, Elizabeth, do you want to contribute?
I just want to add, and this is very critical, just as what Jerusha said, the way we say cough is considered normal, you can see that she had a delayed diagnosis by going to different chemists. And just as Dr. Margaret said, they're targeting the small chemists so that they can also refer those patients coming for just a cough. And you can see by the time they come to the hospital, it's too late for us. And thank God she went to one of our public facilities and she was able to diagnose to have TB. So just to come to her, it's her first time she got a TB. And I can say we have the natural resistant and acquired in resistant and also initial resistant. Maybe she stayed with the contact. She was a contact of somebody who had a drug-resistant TB. When you stay too close with somebody who had a drug-resistant TB, you are most likely to get the resistant type of TB. But we also have the natural resistant, where this occurs even if you've never used drugs. And this can occur to any other form of of disease, that the bacteria usually multiply, just the normal way it multiply. So it reaches a peak, then it undergoes the genomic mutation. So you'll find there's a mutant that come out that is resistant to the drugs. And this mutant multiply. So this occurs even without using the drugs. And some people, we diagnose them, the first time we diagnose, they've never used the drug, they have this resistant type of TB. They could be a contact of somebody who had drug-resistant TB. They had frequent contact with these people, then they were able to get the resistant type of TB. Then we have the acquired one. Acquired mean you've used a TB medication before. Yeah, maybe due to poor adherence, you've not taken your medication well, you're taking, leaving, this selection. Yeah, the bacteria will change and will be resistant to the drugs that you're using. So it's very important. We even advise our patient, and as you're going to see, as we are going to talk about the treatment, once we start the treatment on TB medication, 2 weeks, the patient feels very good.
Yes.
Because we kill the active multiplying bacteria. So the patient will feel very better. The cough will subside, but we need to target even the dormant bacilli. For TB, we have the active and the dormant. This dormant is the one that later on can multiply and cause many complications. So we advise our patient, once they feel better, they need to take their medication throughout the treatment so that we don't get this type of acquired resistance.
And there's also that aspect of exhaustion, you know, for medication, because we know sometimes treatment may take a bit of time, you know, but again, we'll talk about that as we continue in terms of like the interventions and all those things. But very quickly, I also came across drug susceptible. Is it drug susceptible? TB? What exactly is that?
Okay, thank you very much. And just maybe to start with, we have majorly two types of TB. The TB that is within the lung field, what we call pulmonary. It's the most infectious because the patient is coughing, they are emitting the bacilli in the air. Then, as Dr. Margaret said, we have extra pulmonary TB. This is TB outside the lungs. You can get TB of the bone, TB of the brain, TB of the heart. And the presentation is different.
Except your hair and your nails.
Yes, thank like you. You're a good student for that. Then now we have drug susceptible TB. In normal treatment, the patient that we diagnose, treatment usually takes 6 months of treatment. That is the patient, the drugs that we are using, for 6 months, your patient will be cured. That is now the drug susceptible TB. A patient who doesn't have resistance. So when you use the normal drugs, they get well, they feel better. After 6 months, we say the patient has been cured. Then now we have the drug resistant TB. What Jerusha was saying that she had, and this one, it means that the first line drugs have resisted. We cannot use the first line drugs. So we need to go to second line drugs, which take a longer period. We treat even up to 20 months.
And of course, with exhaustion comes in in that area. All right, let's go back to Jerusha. So you were immediately admitted when you got to KNH, right? They told you cannot go back. You cannot go back home. And of course, you thought initially that TB treatment would take like 6 months and you're out of it, which is usually the case, right? For the susceptible? No.
Because she had drug resistance.
This other type of TB, 6 months you're good to go. But for her, you were what, 18 to 20 months. Take us through that period. What was that like? And first of all, just being told that this is your diagnosis, that you do not only just have TB, but you have the multiple drug resistant TB. What was that like? How did you receive that information in that period, you know, in the hospital?
Immediately when I was taken to isolation TB, the doctors brought for me counselors from KNH, and they advised me that this TB you are having, it's not a normal TB, it is a drug-resistant TB. So drug-resistant TB, you have to take a drug for 18 to 20 months. But this...
How many tablets, maybe injections, all those things?
There was no injection by that time. Because I was having many complications, TB affected my bladder. So I used to take 24 tablets for the start in a day. In a day. So it was not easy journey. I used to cry for nurses. Nurses have to twist the story so that I can take these drugs. they used to mobilize me. They used to tell me, just take drugs. If you don't take drugs, you will be normal.
Yeah.
Pick the picture back. You have left your kids.
Yes.
By that time, I was having a kid of 4 years.
Oh, wow. Yeah.
So you don't know where she is by now. Please, if you take these drugs well, you will go back home.
Okay.
If you are alive. So if you don't take drugs, the solution is death. So just take drugs. They used to tell me everybody in this world is taking drugs, not just for TB, but for other diseases.
Yes.
Some are having pressure, they used to take their drugs. Some are having sickle cell, they used to take their drugs. So just take drugs.
Yeah.
So I used to take these drugs, but I used to wonder, how long will I stay in this world without seeing my kids? I don't know where they are, how they are at
You have to
home.
constantly worry about your children.
By that time, even my brain, akili yangu ilikuwa imeruka. So even my phone was taken away from me.
Okay.
I was not having a phone. I don't know what is happening back. I don't know where I am, because in isolation, you are one person in one room. There you have a sink, you can wash your eyes, you can drink water. But I cannot go even to that sink. I used to call nurses. The reception is far away from these rooms.
Yeah.
Nobody will hear you, but there is an alarm. If you point that alarm, the nurse will come.
Nurses will come. Yeah.
Will give you what you want. They used to nap in with me. They were wearing me a
Adult
pamper. Pamper.
Okay. Yeah.
So I used to ask myself, am I now a child? And I said, it is me and me alone.
Yeah.
And it is me with my life.
Yeah.
And I asked God, give me another chance.
I like that.
And God gave me another chance.
Yeah.
Because my brothers, they had lost hope of me. If they saw me, they said that this is not Jerusalem we knew. This is somebody else. Let us prepare for something else.
Okay.
They had already lost hope of me.
Yeah.
By that time, I was staying single. I was a single mom with 2 kids. My firstborn was at class 7. And you know, those years, children were studying 3 months, going to another classes. So I said, my child, if these people are telling me that I will stay in this world for even 1 year, and they used to tell me that there is somebody here who has stayed for 2 years without going back home. So I used to say, will my daughter even sit for her exams
Without you.
without me?
Yeah.
And I asked God that, please give me good health. I used to take these drugs. In that ward, nobody was allowed to come and see you, except those nurses and doctors who are coming to see you. And if they come, they sit like that point you are sitting, and you are on bed.
Yeah.
They talk to you. These counselors counsel you when they sit there. The only person who will touch you is a nurse.
Okay.
And a nurse will wear a mask.
Yeah. Just make sure that they're well.
For the
they're well
prevention.
covered. Yeah. I mean, and I can totally understand that amount of time alone in isolation. It really can, you know, affect, you know, one's mental health. And Dr. Margaret, I want you to really quickly talk on the role of counselors, because again, someone has to be on medication for Jerusha's case between 18 to 20 months alone in isolation and all those things, because majority of the times we just focus on mezadawa, you'll be okay, right? And then involving counselors, you know, I want you to speak on their role and how this helps when it comes to TB treatment.
Yeah, certainly. Once someone is diagnosed with TB, and more so with drug-resistant TB, one of the things that you see is that people tend to lose a lot of hope. And this is where, so they need extra support. And that extra support needs somebody who is properly trained and who has experience and has the ability to support the patient, more so to be able to find local solutions to deal with whatever challenges that are there. And this is where adherence come in.
Yeah.
And adherence counselors really walk the journey with the patients. If they are not able to take their drugs, and some of the reasons when it might not be possible to take the drugs is when you experience side effects. Like when you take these TB medications, side effects is one of the common things. But if you're to weigh the risks versus the benefits, the benefits really outweigh the risks. So it's mandatory that treatment does continue. And this is where the adherence counselor comes in and walks that journey with the patient.
Okay.
There are also, for clients who are out in the community, there are also support groups that are formed, so that these groups come together, and those who have walked the journey, good clients like Jerusha, who have a very impactful story to share, they're able to encourage many others to complete that cycle of treatment, because if the clients fail to complete their treatment, then the TB becomes even more resistant, and there's risk of it spreading over and over again in the community. And our government, you'll realize we have so many priorities. This component of adherence counselors, most of the time, it is not strongly supported by the government. And that's where you'll see now other partners just coming in through different innovative models, different channels, to see how to be able to support and ensure that Kenyans, we are really getting the support that
is much needed. All right, how about we take a break? And of course, when we come back, we'd want to understand, so when it comes to treatment, what are we looking at? Are there interventions and innovations, that are available? And of course, Jerusha, you'd also take us through, your period and how you were able to adhere first of all to medication. You went back to see your children and how you're doing right now, and of course the role that you're also playing to educate the people. I mean, you're here today to help us with the same, which we really appreciate. But let's take a break. But if you have any question as far as TB or tuberculosis is concerned, again, you know the drill by now. At NTV Kenya, both on Facebook and on Twitter is how you can reach us, or better yet, our lines are open, so give us a call, and of course this panel will answer all your questions. But all that is coming up after the break. Stay with us. Margaret, you also want to expound, on more of the challenges that, TB patients would actually face, because again, we talked about, the whole aspect of, social, impact.
Exactly. Certainly, you'll see most of the costs that are costed in the system are mostly medicinal, for the medicine, diagnosis. That's the cost that really is there. But there's this other heavier cost, the social impact cost, that really weighs down households. And when you look at a mother of a household, they're really the ones who are running that household. And if they collapse, it gets even worse in that particular community. So the social component is quite catastrophic, where you'll see patients really, they lose their jobs. You're not able to even provide for your family. And this is where there's a call even for employers to be more empathetic amongst the employees, especially those who are diagnosed with TB and even other social related illnesses, because this is one of the diseases where we live in a very communal society. You breathe out, especially in a crowded place, somebody else breathes in the same air, and it does spread. TB is it's one of the diseases where we say it's TB anywhere is TB everywhere. Everywhere, literally. If you see the goal for 2030 is that we can end TB by 2030. Let's say, for example, by some form of miracle, if you look at Kenya, I talked of 90,000 cases diagnosed last year. If you look at Kenya, and let's say one county, by some form of magic, like Kiambu County, really eradicates or really ends TB, there's still a lot of movement. We are a very mobile society. So it's not only a one area's affair, but the entire country and the entire globe really need to rally our forces towards ending this TB, because it is possible. It has been eradicated in some places in the world. It is possible to end TB and really stop this form of suffering that can be preventable. And just by closing that chain, that loop, where there's no person who is holding the disease.
And because then I'm looking at our time, I really understand, what it means for someone to be told, listen, you are now discharged, you are now okay, you can easily go and, integrate and interact with people around here.
Very important, because by the time a facility is discharging a client, they are very, very sure, more than 100%, 100% sure that TB cannot be transmitted once they are integrated back into the community. And that's why the system goes to great lengths to ensure that this client stays within an isolated space for the duration that it takes towards getting treatment. Unfortunately, the patient suffers a lot while alone, but once they are released to the public, it is very safe. There is zero transmission. A lot of tests has been done. There's a lot of reassurance that once a client is out there, there's zero chance of them transmitting the disease to
the next
anybody.
person.
And just to add, we do integration also. Now we are releasing them to the community. In fact, most of our patients, they are community-based. It means we are treating them from the community. As we release them from the treatment, we usually do counseling. You see, Jerusha said she lost her job. So we try to do counseling. There's a small support that they usually get through Global Fund. So we usually counsel them. Can they start a business? Can they do this? So that as they are going home, they are out of TB treatment. They don't look lost. They are supported throughout. So it's something that we usually also talk to our client. As she said, she was told earlier that now your sputum is negative. We are about to release you. It's preparation. We prepare our client. Yes, now you'll be out. What can you do? How can you prevent TB? How can you be an ambassador? How can you integrate in the community? Even the workspace. How can you also go back to your working? So it's something that we do to our patients so that they don't feel left out once they are discharged from treatment.
Okay. All right. And before we come back to Jerusha, because you benefited from the same, you're able to start, a business, which you'll take us through that very quickly. But Elizabeth, there's this concern about the length, as far as treatment is concerned. And lots of people ask, will we ever get to that point where we have 3 months at most?
Why not?
Or 1 month, right?
There are trials done by WHO. I know there's a shorter regimen. We had one that we were treating for 9 months, but this was injection, and our patients were getting a lot of complication. Deafness, which was permanent. They are getting a lot of side effect because it was a pump-up regimen for 9 months. So that one we stopped, I think, after 2 years. It was not working for us. But I know there are trials with the new molecules that we are using to shorten the length of the treatment, even to 6 months. So these are trials, and I know other countries are doing piloting, but Kenya, we are yet to adopt it. We are still using now the injection free for 18 months, but it's something, maybe when we come, maybe 2-3 years, there will be a shorter regimen for drug-resistant TB.
Which would be a really, really good
Even
thing.
for the normal TB, we used to treat it for longer. We used to treat it for longer, for 1 year. It has gone back to 6 months. Maybe very soon it will be 3 months. Because of many research that has been done. But I know for the drug resistant, the new molecules are being tried, and I know will shorten the treatment.
So I think
also
in the meantime,
there's technology that is being utilized to support. Elizabeth talked about DOTS, directly observed therapy, where you'd have to be seen by a clinician or a nurse or a healthcare worker, somebody else to be seen so that they ascertain that indeed you're taking the medicine. Now there's also use of technology with videos, there are cameras everywhere. So there's use of technology so that there's reduced transport costs for the patient. Instead of them having to move to this point to the facility, they can just use their phone and adopt other measures to be able to be seen to be adherent to that medication. And it's really supporting the clients in reducing the cost,
which we talked about, because like you said, we focus just on the medication and they stay, in hospital. We'll talk about the whole question about TB, treatment being free. Really expound on the same, but very quickly on Jerusha. So how are you doing right now? You were able to start your business. How's everything? How are your children? All those things we want to see. We want to hear the good part. After the long journey on treatment.
No, I thank God that I'm good. By now, the PSK has helped us a lot. It has helped us through counseling. There is a meeting we used to go for counseling with the caregivers every month, which is supported by PS Kenya. If we go to that meeting, they give us lunch and fair transport. And if they give us this money, you can start now your business. Even if it is little, you can start a little business for your support. So they have also helped us through empowering us They told us to form group, and we formed a group.
Okay.
And we registered this group. They supported this group with the 100,000 shillings. This group, this 100,000 shillings, we started now a business, which is now we are a group called Nebula Stars Group.
Ooh,
And
I like the name, Nebula Stars. Okay.
Yes,
Yeah.
and we have opened a business which is an hotel. Now we have a Nebula Stars Hotel located at Embakasi North, Dandora Phase 1, opposite Total. There we have an hotel.
Okay.
And there is a good food there. If you travel in a long dust road, please look where Nebula Stars is. You will get nice food from there.
Do you have samaki?
Yes, we have samaki, we have omena.
And everything else that one would need.
Okay. We have samaki, we have omena there. We have samosa, we have mandazi, mahamri.
Yes.
Everything
that one would want.
Oh,
Okay.
yes.
But then again, aside from that, so are you helping the community to, talk about TB, and especially on the prevention part? Because again, like we said, we're still on the long regimen, it's fine.
Yes.
But again, we'll look forward to those days when we have shorter regimen. But in the meantime, we can focus on prevention. So what are you doing to the community to help them understand about TB?
Yes, I'm not afraid to tell somebody that I was a TB patient.
Yes.
Yes, if I look at you and I see you are so sickly, I can tell you that, please just visit a public facility, get tested. TB is treated, na TB inatiba.
Yes.
It is free in a public facility. It is free even kwa easy clinics za makanisa kama IDAP, it is free. If you go there when tested positive, please take your drugs. Kubali juni wewe na accept it. If you accept it, you're gonna make it.
It makes it easier for you to adhere to the regimen. I like that. I like that. All right. So Dr. Margaret, in terms of then, because like we said earlier on, this is a collective effort just to make sure that we end this by 2030. So yes, the government is doing its part, right? But what are some of the things that other partners can do to contribute towards this?
Exactly. I want to re-emphasize that the government is the coordinating body so that there's no duplication of efforts. The government is very clear that this is what needs to be done, and partners can now step in using the master plan that has been provided very clearly by the government. They are clear that this is what we want to do. There's a clear roadmap on how we'll end TB, or we are working towards ending TB by 2030. And they're very clear on what has been done, what is ongoing, and where the gaps really are. Right? And that's where now other partners now come and step in. If they're diagnostic, perhaps the diagnostic tools are not sufficient, then partners now can step into that, ensuring that facilities are equipped, the healthcare workers are fully trained, that there's also advocacy, so that there's additional resources. Resources are never enough, but there's that form of, there's advocacy for and on behalf of the clients and the patient to ensure that they get that kind of support. There's also a lot of behavior change communication that is currently ongoing by partners like PS Kenya and also many other NGOs in the country supporting that as well. Civil society organizations, health insurance, so that health insurance not only caters for all the other illnesses, but also TB is really, so just working very closely. The National TB Program gives clear guidelines. Any partner who wants to come in and support, their doors are open. The Nairobi County government has shown very strong leadership in this space with the slogan, let's make Nairobi work, over and over again. There's very clear leadership in that. So it's about really all the stakeholders coming to the government and getting clear direction. Their contacts are available on their website. PS Kenya is also available to provide that kind of information. Media, yourselves also coming in very strongly to talk about this. And most importantly, the individual, they must step up and own. Ignorance is no longer bliss. People need to feel fully empowered, educated, show some form of interest, and also supporting each other.
Empathy.
And stigma reduction. Because when there's stigma, people delay in getting to seek treatment, going to seek diagnosis. They take too long, even up to 6 months, sometimes even a whole year. And when you show up late, it's when the disease has already progressed. There's a lot of complications. Treatment is more expensive. So it costs much more.
I see that. All right. So Elizabeth, would you emphasize more on the treatment aspect, and then we'll do a parting shots because we literally need to end the conversation. But let's talk about the treatment, as far as TB is concerned.
Thank you so much. And as Jerusha and also Dr. Margaret have said, treatment is free at the government and faith-based facility. But when we say free, there's somebody. The government is catering for the cost. For the same, yes. Yeah, it's very important. Jerusha talked about she had a bill of 1.6 million, and all that was paid through NHIF and through support of the partners through Global Fund, so that we ensure our patients who have complication, who have TB, while they're on medication, they are able to have the NHIF card, and this is also paid. So NHIF is the way to go to ensure we support our patient. So government facilities, faith-based is free. We do free diagnosis at the site. And I want to say our healthcare workers have the knowledge. We have trained them. Yeah, immediately she went to Dandora. She was diagnosed. We didn't waste a lot of time because we have trained most of the healthcare workers on TB. They know the signs and symptoms. So it's just a prompt of the client coming. They don't waste their time. For the private sector, we are doing private sector also. Public-private sector, as also Dr. Margaret was saying, just to partnership with the private sector. Currently, I know because of the expense of treating drug-resistant TB, we are not having a private sector treating drug-resistant, but they are doing diagnosis. They are doing diagnosis. We didn't have a proper linkage, but now we have a linkage through that partnership. Once they get a client, we are able to support the client because of the issue, drug-resistant. It's not a patient you give them nendo kunywe dawa, come here after 1 week or 2. So it has to be observed. And those we talked about catastrophic cost. We don't want our patient to incur catastrophic cost for us to end TB. So you'll find that once they are diagnosed, they come to us, we support this client. Isolation, we see how best we can support this client so that we reduce that amount. But treatment, even the private sector, it's also subsidized. It's not that we can say it's like no. We have partners that is supporting
we're literally being chased out of the studio, but my 30 seconds please, so that I can give you a parting shot very quickly on the county government of Nairobi and of course the plans in literally 5 seconds.
We talked about community. I think we are having, because the healthcare workers, they are all trained. We have, and I know our governor, as really we are supporting the community volunteers. They are the ones that are going to the community to do a lot of health education, to do contact tracing. So they support, the government is supporting this, the county of Nairobi. We have also done the CIDP, the county integrated development plan. And we have support, the county is supporting TB for us in Nairobi. We have trained the healthcare workers. So
Elizabeth, I see you. Jerusha, I want you to speak to the people watching us in literally 5 seconds. Mikey, please, 5 seconds, and then we'll close with Dr. Margaret. Unazambia nini watu who are watching you, this morning?
What I can tell people outside there, please avoid discrimination, avoid isolating people living with TB. TB is treatable, TB na tiba. Na wale bado wako kwa madawa, tafadhali kanuni za daktari, meza dawa na ujue maisha ni yako na ni yako.
I like that. All right, Dr. Margaret, right? She has said it all. Okay, all right, and we end it here. Thank you so much, ladies, for coming by today. I know 1 hour is literally like this much, but I'm happy that we've started this conversation. So thank you so much, Dr. Margaret Njenga, acting CEO, PS Kenya. We had Jerusha Anyango Odwar, TB champion, as well as Elizabeth Mweni, County TB coordinator, Nairobi County Government. Thank you so much.